Thank you for the opportunity to talk about intracardiac thrombus and how I manage them. My name is Dr. Arman Qamar. I'm a vascular medicine specialist and an interventional cardiologist at North Shore University Health System. These are my disclosures. So, as a background on this topic, intracardiac thrombus is a major cause of ischemic stroke and systemic thromboembolism. It is most commonly encountered in the setting of people or patients presenting with anterior myocardial infarction. Now, anticoagulant therapy, that is usually the standard of care treatment for intracardiac thrombus, is challenging because many of these patients who develop intracardiac thrombus, they also need a dual antiplatelet therapy because of concomitant PCI, which included coronary stent placement. What are the causes of intracardiac thrombosis? Now, this has been evolving. The most common cause of intracardiac thrombus formation usually has been, and again, if you look at the overall data, it is still myocardial infarction, usually the anterior myocardial infarction in the setting of ST segment elevation MI. The other causes are all listed over here, but that includes quickly dilated cardiomyopathy, so patients with heart failure with reduced ejection fraction, those with Takotsubo stress-induced cardiomyopathy, cardiac amyloidosis, both light chain and TTR amyloidosis, an interesting clinical entity called hypereosinophilic syndrome or called Loeffler syndrome is associated with intracardiac thrombus, usually LV thrombus. Chagas disease, most commonly you would see this in South America. Atrial fibrillation, very common in our aging population, usually contributes to formation of thrombus in the left atrial appendage. Cancer can cause thrombus formation in any of the heart chambers. Patients with venous thromboembolism would usually have intracardiac thrombus on the right side of the heart. Patients who have a pacemaker or defibrillator are prone to thrombus formation too. Patients with antiphospholipid antibody syndrome, those with connective tissue disorders, particularly those with Behçet's disease, and patients with apical hypertrophic cardiomyopathy, also called Yamaguchi's disease, are all prone to formation of intracardiac thrombus. Now, as I mentioned to you early on, that the causes of intracardiac thrombus are evolving. Shown here is the data published by my good friend Kian McCarthy. It was published in JACC last year. He, along with the other co-investigators, looked at 128 patients who developed intracardiac thrombus across the Harvard hospitals. And what they found was that the number one cause of intracardiac thrombus formation, they looked at LV thrombus, so it was heart failure in blue, followed by ST segment elevation MI, then NSTEMI, and then stress-induced cardiomyopathy, hypertrophic cardiomyopathy, and there were a few patients who had ventricular assist device who also had intracardiac thrombus formation. Now, the prevalence of intracardiac thrombus in the current era, very variable, depends upon what registry you looked at. Did that registry include patients with MI or did it include all comers? In general, close to 0.5 to 15% of the patients presenting with anterior wall MI will have intracardiac thrombus. Most recently, or the largest data that we have is from Ram et al. Their analysis included more than 150,000 patients with anterior STEMI, and 0.5% of those patients, they had intracardiac thrombus. Prevalence of intracardiac thrombus in other registries, in registries of dilated cardiomyopathy, the prevalence has been somewhere between 60 to 50%, and in those registries and the other registries of Takotsubo cardiomyopathy, 3 to 5%. It is very interesting to note that 1 in 4 patients with cardiac amyloidosis will have an intracardiac thrombus, and 1 to 2 patients with Behçet's disease, a connective tissue disorder, or they have intracardiac thrombus. What is the pathophysiology of intracardiac thrombus? Now, the illustration here is quite similar to what you see for Warkow's triad for development of venous thromboembolism. There are 3 components to it. Usually, to develop intracardiac thrombus, you need to have abnormal blood flow. Now, you would have that if you have a depressed systolic function or if you have anterior apical ventricular aneurysms. There could be tissue injury in the setting of myocardial necrosis from a massive heart attack, or in patients with connective tissue disease or hypertrophic cardiomyopathy from stress. That contributes to it. But most importantly, hypercoagulability plays an important role, which happens because of increased platelet reactivity and activation, higher plasma levels of fibrinogen and von Willebrand factor, and increased pro-inflammatory cytokine activity. So these are the different kind of pathophysiological underpinnings that contributes to intracardiac thrombus formation. Diagnosis of intracardiac thrombus. Most intracardiac thrombus that you'll see would be first seen on a transthoracic echocardiogram. On the left, you see a very well demarcated hyperechoic thrombus, which is present at the apex. Whenever you see that hyperechogenicity, it suggests that the thrombus has been there for a while rather than few days. That's in the apex. At times, you might need a contrast. So seen here is an echo using echo contrast, and you see the thrombus nicely. There's another thrombus that you see, again, stuck to the infraseptal wall and the apex on this echo. Now, cardiac MRI is the gold standard modality in the evaluation of intracardiac thrombus. So when I have high suspicion that someone could have my intracardiac thrombus and I don't see it, or I don't see it too well on the echo, I always go ahead and get a cardiac MRI with contrast. Another advantage of cardiac MRI is that it will also tell you, if you're looking at a patient who just had a heart attack, about what are the chances that the patient is at risk of thrombus formation in long term. With that, what I mean is, if the MRI shows that that particular area of the heart is dead, that means they're going to remain akinetic and the patient would be at an increased risk of thrombus formation in future too. However, if it suggests that the area is alive, then more likely that particular area of the heart is hibernating or stunned, and with time it will get better. So treat the patient with anticoagulation for a few months, and and after that the patient should just do fine. Again, this is another LV thrombus at the apex in the setting of a heart attack. Now, a different disease presents with thrombus in a different way. The cardiac MRI here on the extreme right shows you a thrombus in the setting of hypereosinophilic syndrome. They are very prothrombogenic, and the thrombus is very extensive, involves a couple of walls, including the apex. So just the type of thrombus, how it looks in MRI, can tell you what the disease process could be. Now, at times you would do a TEE, and that would lead to discovery of a left atrial thrombus. Shown here is a TEE of a patient with atrial fibrillation, and you can clearly see that this particular patient has thrombus in his left atrial appendage, which is a major risk factor for stroke. So again, kind of a different type of intracardiac thrombus, different from LV thrombus. Now, people frequently ask me, what is the risk of embolization in intracardiac thrombus? It depends on what kind of patients you're looking at and what registries you're looking at. In general, the annual risk of embolic event in patients with intracardiac thrombus is 2 to 6%. But again, this risk also depends upon if you're anticoagulating them. If you are anticoagulating them, are you anticoagulating them enough? And with what particular agent? It is important to note that the risk of an embolic event is highest in the first 2 weeks after MI. Y-axis here shows you the rate of embolic event, and the x-axis here shows you the months after LV thrombus. There's one study by Valangi et al., which is an outlier, that shows you that over a long-term follow-up, the risk is still 10 to 14%. But most studies, they generally suggest that the annual risk is somewhere between 2 to 6%. Now, again, what annual risk of stroke you get depends upon for how long these patients were anticoagulated and what was really the cause. The bottom line is, if you develop LV thrombus, your risk of stroke always remains high compared to the general population. So I need to take care of them carefully and monitor them for development of systemic thromboembolic events. Shown here is a study published in Circ Cardiovascular Imaging last year. In this particular study, the investigators looked at patients who had LV thrombus and compared to them to patients who did not have LV thrombus. And all patients with LV thrombus, they completed anticoagulation for a period of 3 months, and then they were off that. And then what you're seeing here is x-axis shows you time after cardiac MRI, which had shown thrombus formation. But importantly, the y-axis shows you the risk of embolic event. So in this particular study, they followed patients for a period of 3.3 years. And what they found was the patient who had LV thrombus, even after 3 months of anticoagulation, the annual risk of stroke over a couple of years of follow-up was 4 to 5 times of that of patients who have never had an LV thrombus. So the bottom line is, if you had LV thrombus once, you're always at a high risk for ischemic stroke and peripheral embolism in the future. Now, what if we knew that a patient had LV thrombus and that a thrombus had resolved, compared to those patients who had LV thrombus and the thrombus did not resolve? This is a study that very recently was published in JACC. They initially looked at close to 90,000 echoes, but they found 159 patients with LV thrombus, followed them up for a period of 1.7 years. And then they categorize patients in two categories: patients who had complete LV thrombus regression, those who did not have LV thrombus regression on any of their echo. Now, when was the echo checked? Variable. Most echoes were done between 3 to 6 months. Bottom line is, the key thing to note here is that these patients, there was no difference in the rate of thrombus regression between patients treated with warfarin and a direct oral anticoagulant. But what they found was that patients in whom you achieved total thrombus regression compared to those with persistent thrombus, those with persistent thrombus, the survival rate was very bad. Now, the risk of death was 50% lower in patients who had total thrombus regression than those who did not achieve total thrombus regression, which raises an important question, that when you see a patient with intracardiac thrombus, should resolution of thrombus be one of the endpoints that you should follow up at? And really change their anticoagulant therapy only after the thrombus has regressed. Now, these are again in patients who have reversible risk factors that led to a formation of a thrombus. Okay, moving forward, which is an important part of the talk today, how do you treat intracardiac thrombus? Now, shown here is a summary of the key recommendation from all the authorities or the guidelines on how to manage intracardiac or LV thrombus. Now, again, you can review this at your convenience, and would not go ahead with each of them individually. The bottom line or the take-home message from this particular slide is that the most guidelines, they suggest that once you have found the LV thrombus, you need to be anticoagulated. With what? Most tell you that you need to treat them with warfarin, and only if the patient has a contraindication or cannot take warfarin, then only you do use a direct oral anticoagulant for the treatment of LV thrombus. Now, for how long? Most guidelines tell you to treat them for a period of 3 to 6 months, but some of the guidelines do tell you, as is the example in the ESC STEMI guidelines, that says, in case of definite thrombus, anticoagulation for up to 6 months, guided by repeat imaging. So in general, the take-home message from this slide is, if you have LV thrombus, you need to be anticoagulated. The guidelines are telling you warfarin over direct oral anticoagulant, but we don't have any data to suggest one is better than the other. And then you need to treat them for a period of 3 to 6 months and make sure that the thrombus is resolved by serial imaging, maybe 3 months, 6 months, and even more serial imaging. Now, what are people really treating in LV thrombosis with these days? So let's see. This is the data again from the Harvard system that Kian McCarthy had published in JACC. And what they found was they looked at 128 patients. Now you can imagine the sample size of these studies are so small because there's not much data on this topic. N of 128 patients with LV thrombus. In-hospital death rate was 8%, and one-year mortality was 13%. What Kian and colleagues found was that the warfarin appears to be the most frequently used treatment, followed by low molecular weight heparin, and apixaban and rivaroxaban just getting started to be used, but still not being used in a lot of patients for treatment of LV thrombus. Shown here is another data that was published in JAMA Cardiology this year. This is a trial which collected data on patients who had LV thrombosis across 3 healthcare systems, including University of Virginia and University of North Carolina. They identified 514 patients who had LV thrombus. They were followed for a period of 1 year. They performed a retrospective observational analysis, and what they found was 300 got warfarin, 185 got a DOAC. What they found was that if you got a DOAC, you were associated, DOAC in these cases would be associated with an increased risk of stroke and embolism, hazard ratio of 2.65. So more than close to 3-fold higher risk of stroke or systemic embolism with the DOAC compared to warfarin. Now, what they also found was that 8.7% of the patients who on imaging were found to have a resolved thrombus, they also developed stroke or embolism, which again brings into attention that there are 2 important take-home messages from this slide. They raise concern that maybe DOACs don't do as good of a job in preventing stroke compared to warfarin in patients with LV thrombus. My take-home message from this study is a very important study, but we need more data. This is observational analysis. There is a lot of hidden, unmeasured confounding, and are inappropriate or not scientifically valid to compare one treatment group to another. But it raises a question that we need randomized controlled trial data comparing one anticoagulant approach to another in patients with intracardiac thrombus. But another take-home message is that even though patients have been found to have resolved thrombus. Even close to 10% of them are still developing stroke or systemic embolism. That brings into question that a lot of these patients probably have systemic risk factors. Maybe they have atrial fibrillation that might have not been detected well. They probably need to be monitored more, maybe with a link or a 7 to 14 days ZO patch. And if they have atrial fibrillation, they have an indication for anticoagulation. Maybe some of these patients have bad carotid artery disease, and that needs endarterectomy. And so again, some of the things that needs to be addressed in why 10% of these patients, despite resolution of the thrombus, were developing stroke or embolism. Another study in American Journal of Cardiology from our friends at Mid-America Cardiology, they looked at 52 patients who had LV thrombus, followed for 1 year, retrospective observational study. 26 got apixaban, 24 rivaroxaban, 2 got dabigatran. 83% underwent follow-up echo at 6 months. What they found was that 83% of these patients, they had complete resolution of the thrombus after getting a DOAC. So it seems like it's not that DOAC does not work at all. We are seeing that it works. However, one patient of these who had complete resolution thrombus still developed a TIA, and the cause of that could be multiple factors. I mean, it could be 100 risk factors which could be contributing to that, and very important to look for those risk factors in your patients. Okay, so how do I manage intracardiac thrombus? So I take all the background information that I just shared with you in deciding how to manage intracardiac thrombus. This particular table was very nicely presented in a recent review article on this topic in the European Heart Journal. So the key is to first keep an eye on who are the high-risk patients who are at high risk for forming LV thrombus. Those are patients who have anterior apical STEMI, people with large acute MI, those with EF less than 40%, patients with history of stroke, TIA, who have dilated cardiomyopathy, HCM, Takotsubo syndrome. Yeah, get a TTE as an initial test, but pay close attention to akinetic and aneurysmal area. If you're not sure that there is a thrombus or not, consider doing a contrast echo, cardiac MRI, and also consider even consider a cardiac CT scan based on what advanced modality you have. If a patient has LV thrombus, they just need anticoagulation. Now, what form of anticoagulation? Again, the take-home message is there is no randomized clinical trial data to guide you regarding what treatment is better than another. I think you should anticoagulate them and anticoagulate them with an agent that you feel very comfortable with. In my practice, I most commonly use a direct oral anticoagulant because I'm impressed by their safety compared to warfarin in treatment of patients who have either have atrial fibrillation, venous thromboembolism. So again, since there is no LV thrombus trial data, so from some of the other trial data and other patient population, the data that we have suggests that the DOACs are safer than warfarin. Patients like the idea of not getting their INRs checked frequently, and also that they can enjoy and eat healthy green salads. So direct oral anticoagulant, I frequently either use apixaban or I use rivaroxaban. And but if you're using a vitamin K antagonist or warfarin, make sure that you bridge them with low molecular weight heparin. Now, if patients are not a candidate for either, then in that case, you'll have to use Lovenox. Now, one clinical scenario that you would frequently run into in managing LV thrombus would be a patient who recently came in with a massive heart attack or STEMI, and they need to be on dual antiplatelet therapy because for their coronary stent in addition to a oral anticoagulant. So in that setting, my approach is, if they recently got a stent, instead of treating them with a long-term triple therapy with aspirin, a P2Y12 inhibitor, and a anticoagulant, what I do is I treat them for triple therapy for 1 week, and then after 1 week, I stop their aspirin. I do pharmacogenomics testing if I'm using clopidogrel, and if they're a full responder, then clopidogrel plus a direct oral anticoagulant would be my long-term treatment. For those patients, I repeat an echo at 3 months and make sure that there is no thrombus and the apex is moving well. If I'm worried, then I would repeat another echo or even an MRI maybe at 6 months. And if at that time the thrombus is resolved, the apex is moving nicely, and it's no longer akinetic, I would stop their direct oral anticoagulant and put them back on aspirin plus a P2Y12 inhibitor. If your patient is not a full responder to Clopidogrel, based on genetic testing, or if you did like to do a functional testing with a P2Y12, verify now, I say I use a cutoff for 208. A value of 208 and clopidogrel or more suggests you are not a responder. So for non-responders, I would switch them to either prasugrel or ticagrelor. Now, like I said, you repeat a contrast echo MRI in 1 to 3 months, and again, if not resolved, just follow them. Longer anticoagulation is needed. Now, if a patient does not have LV thrombus, no anticoagulation, but do reevaluate in 3 to 6 months and make sure that no new thrombus has formed, because some of these patients may not have a thrombus early on. But if the apex and the anterior wall is akinetic, they're at risk for forming thrombus in future. So I would say repeated echo in close to 3 months, even consider MRI. So in summary, LV thrombus was a major complication of MI in the past. In the era of primary PCI, in which we take most of our STEMI patients for primary PCI within 90 minutes, we now see LV thrombus from a variety of other conditions. So you would remember the nice table that I showed you earlier in the presentation. The risk of adverse events, death, stroke, systemic embolism are high in patients with LV thrombus. Anticoagulation can likely be achieved with a variety of agents, including direct oral anticoagulants. Patients should plan for at least 3 months of anticoagulation in most cases. Now, remember the clinical conundrum that comes into play regarding triple therapy, recent stenting that I just mentioned. So I think that information will help you with that. And in all these patients, perform a repeat imaging to assess for LV thrombus improvement and resolution. With that, thank you for the opportunity to talk about this very interesting topic, and I look forward to a good discussion at the open session on October 24th.